Okay, to start with, I will talk about the technique for correction of complex clasped thumb. I know that you all know the pathology. The basic abnormality for clasped thumb is deficiency of the extensors of the thumb. Maybe the extensor pollicis brevis, but it also may be combined with extensor pollicis longus deficiency. This is the simplest clasped thumb. But the complex type, which is present in distal arthrogryposis, and especially I don't like the term of distal arthrogryposis because we have a lot of proximal deformities in addition. But this is a classic or prototype for a complex clasped thumb. In addition to the deficiency of the extensors of the thumb, there is a flexion deformity of the metacarpophalangeal joint. This is at the level of the joint itself, contracture of the capsule, and at the same time, there is deficiency of the palmar skin at the palmar aspect of the thumb. The web space has variable degree of narrowing, and sometimes is very narrow, sometimes is not that severe, and there is contracture of the structures across the first web. The skin, there is a skin deficiency, there is contracture of the intermetacarpal fascia. Sometimes there is contracture of the muscles, the first dorsal interosseous muscle, or the adductor pollicis muscle. Also, the base of the thumb, the carpometacarpal articulation may be stiff and needs release to free up the first web space. The metacarpophalangeal joint is also the site of instability, and this instability may not be visible until we are releasing the thumb and releasing the contracture at the level of the metacarpophalangeal joint. But sometimes it is visible preoperatively, and they gave a false impression of wide web. Also, it is a very narrow first web. The articular surface of the metacarpophalangeal joint is a deformed one, and the articular surface is not congruent. It is deformed and irregular, and that's why I think it is not amenable for reconstruction and to restore a movement at the level of these joints. The indication of surgery, if a patient has a clasped thumb and he's unable to clear the thumb out of the palm to allow grasp, this is an indication for surgery. Because in a case like this, although the patient has a classic clasped thumb, but he can clear the thumb out of the palm and has a good opposition, good function of the thumb. So in this case, there is no absolute indication for surgical intervention. The treatment is to address the pathological problems by skin augmentation, a widening of the first web space, by skin augmentation of this web, release of the web space contracture, and to achieve stability at the level of the metacarpophalangeal joint. And in a study we conducted, we used the modified dorsal rotation advancement flap. Scott called it Ghani flap, so I will call it Ghani flap after it. And a la carte release of the tight structures of the first web. So these include the fascia, the adductor muscle, the adductor pollicis, the first dorsal interosseous, and release of the carpometacarpal capsule. And stabilization of the metacarpophalangeal joint by chondrodesis. But I call it arthrodesis because I try to achieve bone-to-bone fusion and not a cartilage-to-cartilage fusion. That's why I wait till I see ossification of the ossific nucleus of the epiphysis at the base of the phalanx to allow bone-to-bone fusion, because this is much more predictable than doing cartilage-to-cartilage fusion. The operative technique, this is an example of a case with severe contracture and severe shortening and deficiency of the palmar skin at the thumb. There is instability, visible instability at the level of the metacarpophalangeal joint. This may give a false impression of wide web, although the metacarpal, the first and second metacarpal are very parallel to each other. Even in the X-ray, we cannot see the first metacarpal bone. Only we can see four because it is very adducted to each other, the first and second one. I use the Ghani flap, and on the palmar aspect, we have to reach with our incision to the axis of the middle finger. Because this is an isometric point for motion of the thumb. The palmar skin incisions may be Z-plasty or inverted T. Both are doing nice. And we have to keep this section on the undersurface of the flap to the minimal as much as we can to mobilize the flap and to keep all the blood supply going out and in as much as we can. Then we go to the release of the tight structure, especially the intermetacarpal fascia. The first dorsal interosseous is released from the first metacarpus and the adductor pollicis from the third metacarpus. And sometimes we have to do release of the carpometacarpal articulation and the base of the thumb. Through the same incision, we expose the metacarpophalangeal joint, and we have to shave the cartilage of the head of the first metacarpus. And at this level, we can do shortening as much as we can to overcome the volar skin contracture by doing shortening at the level of the metacarpals. We are not afraid of anything because the growth plate for the metacarpus at the base is not at the head. And at the level of the base of the phalanx, we have to shave meticulously just to reach the ossific nucleus to avoid injury of the physeal growth plates. And then fix the arthrodesis with a wire. And if I can introduce the wire to the carpal bone, and this will stabilize the thumb in abducted position, I'm done with one key wire. But if this is not the case, I have to add another wire between the first and second metacarpals to maintain widening of the first web. This is an example of a case with severe narrowing of the web space, very severe short distance between the first and second metacarpal, the unstable metacarpophalangeal joint, and this is the appearance after reconstruction. A case of arthrogryposis with we have done reconstruction bilaterally, and here there is improvement of the function and appearance of the thumb. This is a very severe case with very severe shortening of the palmar aspect of the skin. And although it is a very short, I didn't need to add any flaps on the palmar aspect of the thumb. I did shortening at the level of the metacarpals to overcome the palmar contracture, and the flap will correct the rest. This is the case of bilateral clasped thumb also. I operated on the right side and has severe instability, immediate appearance after surgery. And here, after reconstruction, there is a difference between the motion and the appearance. Here she can do good opposition, here only flexion and adduction. And the X-ray showed preservation of the physeal growth plate. This sometimes is mistaken for non-union at the level of the metacarpophalangeal joint, but it is the growth plate, and there is an excellent bone union. So usually these thumbs continue to grow without any shortening. And this, how it looks different between the right side, the operated right side, and the non-operated left side, and the regarding opposition, the movement, how she can manipulate the pin and use it in comparison to the non-operated side, the left side. Lastly, a case I operated upon her 12 years ago, and this is after 12 years follow-up. with complete fusion and the arrest of growth of the stopping growth of the thumb, and here after long-term follow-up with good function and maintenance of good correction. We published our results in 2017 for treatment of congenital clasped thumb in arthrogryposis. We operated upon 69 hands, and we used the same protocol I mentioned, but we did chondrodesis. In all the cases, they necessitated release of the intermetacarpal fascia, but less required release of the adductor pollicis and less required release of the first dorsal interosseous, and almost half the cases necessitated release of the base of the thumb. And we have non-union of chondrodesis in 7 hands and necrosis of the tip of the flap in 7 hands also, but didn't affect the final outcome. And we don't have effect on the longitudinal growth of the thumb. That's why I'm shifting now for arthrodesis and wait for ossification of the ossific nucleus at the base of the proximal phalanx. We have the best improvement in regarding abduction, followed by rotation, and the least as opposition. And in cases of instability, 5 of the metacarpopharyngeal joint, 5 required revisions. So to conclude, surgical reconstruction improved the cosmetic appearance and function. And because the metacarpopharyngeal joint in these cases has a global instability and abnormal articular surface and lack of efficient muscles for transfer, I think fusion of this joint is a good option. I used the Ghani flap, which provide a wide round whip, and proximal retraction didn't affect the final outcome. It is easy, simple procedure with minimal donor site morbidity. This paper has been awarded the Paul Mansky Award for Best Publication in Pediatric Upper Extremity Congenital Difference in 2018 by the Pediatric Hand Study Group. We were lucky for this. Thank you.
Sebastian, I think you're muted.
Yes, thank you. I was muted. So thank you for this great presentation. Hisham, I have 2 initial questions. The first one is, do you start to splint the kids early on? And second one, do you see any role for an early tendon transfer in the not so severe cases or at an earlier stage, like EIP transfer whatsoever?
Yes. I splint the patients, especially if they are not arthrogrypotic. Patient without arthrogryposis or simple cases of clasped thumb, I do splinting. I continue splinting for a long time, and the exercises, I teach the mother to do exercises, and splinting usually should be done in an extended rest position to properly stretch the palmar structures. But not every case of arthrogryposis is amenable for splinting. Sometimes I cannot splint them.
Yeah, I'll send it, right?
So tight, or the palmar skin is very short, then I cannot do splinting. But if I have a chance and the deformity is not that severe and I could do splinting, I will not go I will go for it for a long time, especially during the first year of life. Regarding the tendon transfer, if it is simple clasped thumb with good joint, no severe contractures, then I can do extensor tendon transfer. But the problem, if the patient has deficiency of the extensor pollicis longus combined with deficiency of the extensor pollicis brevis at that time, usually the extensor endesis is absent also. So sometimes we have difficulty in choosing a tendon for transfer.
Yeah. Regarding your flap, we have seen and know your nice flap modification. I also frequently use the stiletto flap you published with Mahmoud Mustafa, and I really liked it, especially for the cases where the web is not so tight here, but more here on the volar aspect. Can you comment on that? Do you do it as well in some cases, or what is your indication for the flaps?
The flap I described with Mahmoud, with Mustafa, he will present it in the next meeting, by the way. This flap is not a stiletto. It is in addition to stiletto, there is another two flaps
Yeah, I
added
know.
to the web. Yes, because I think the stiletto flap is a good flap, but it either address the web space or address the palmar aspect of the thumb. So if it is going to address the web space, it will do fine because I will do shortening to overcome the palmar contracture. So you may say that I'm biased to the flap I use because it solved many of the problem for me, and it is very glamorous and very provide me with a very good skin that I can address many deformities and shortening regarding the whip and regarding the palmar aspect of the thumb. And that's why I have to go with the flap palmarly to the axis of the third ray, because at that time I lengthen the palmar aspect, the skin of the palmar aspect of the thumb, in addition to widening of the first web space.
Yeah, definitely. If the first web space is too tight, then it's a perfect option. Any other comments from the faculty? Maybe Francisco or Scott?
Yeah, here's my, again, Hako, you want to, I have one quick question. And maybe I just make sure I understood what you said, Hisham, in your talk. You now delay the chondrodesis until you see the ossification center of the proximal phalanx. So that's number one. And number two, though, what age? Like when does that typically occur?
Yes, I delay my reconstruction till the ossific nucleus of the base of the thumb is visible on X-ray, because here I'm sure that I will achieve bony fusion at the metacarpophalangeal joint and not cartilage, just cartilage to cartilage fusion, which may not be predictable enough for a good union. Usually, this appear from 2 years and on. So I start to do an X-ray from 2 years. And by the way, sometimes it's very difficult to visualize it because the thumb is adducted and sometimes the ossific nucleus is obliterated from out of view by the metacarpals, the second metacarpal. In hypoplastic thumb, usually the ossification is much more delayed than in cases of distal arthrogryposis. So in hypoplastic, sometimes in some severe cases, the ossification of the base of the phalanx does not appear until about 3 years. But in clasped thumb, usually it's appear earlier.
Can I make a comment? Hisham, there's so much wisdom in everything you just said. And I think for those in the audience who are just starting to do this, I would pay attention to very much the details that he described. So it's not just about the skin flap. And I think Hisham, you went really into detail. It's also the soft tissue releases. It's keeping the flap full thickness. It's maintaining the vascularity of the flap. And I think that I've learned a lot from you, and a lot of what I do now in terms of first web space augmentation has come from you and Mustafa, and I thank you for that.
Thank you.
And I just want to echo a little bit what Dan said. I think one thing you said in the talk for those people starting to do it is the shortening, right? Because the vessels will not tolerate not shortening, if that makes any sense, right? So you need to be fairly aggressive in your shortening in these really bad stuck thumbs that are unstable, or you're going to get into trouble, either arterial inflow or venous outflow. So I just have to echo that for the people starting to do this procedure, because it's not an easy operation. It really isn't. And it requires a substantial amount of thought, process, metacarpal shortening, keeping the flap alive, like Dan said. It's really important. So thank you.
Yeah, and I think also the concepts that you just went over apply very much to cerebral palsy as well. I've started doing stiletto flaps and your Ghani flap for CP patients who have tightening of the first web space. And that's really helped. And the same principles, release the first dorsal from the thumb, release the adductor from the third metacarpal. So these kind of, as basic principles of doing essentially an origin slide rather than cutting the tendon, because if you cut the tendon, you've lost that function. Whereas if you do a slide and take off the origin, you have at least the potential for better function, but in a better location. So again, I think pay attention to the details. If you can go over this recording again before you do this, I think there's so much wisdom in what you just said that it should be something that everyone watches before doing it. So thank you.
Thank you. Thank you for you.
Yeah, I think these are very nice final words, I would say, unless there are other questions.
Just a comment.
Yes.
So it's about first web contracture. So recently I published a paper, a treatment for the first web, and I realized that there is no classification on the severity of first web contracture. It doesn't exist. And there are almost no papers comparing techniques. There is one paper that compares 4 flap set plasty with a stiletto, saying that a stiletto gives more widening of the first web. So I came with like a classification of severity, no, depending on the intermetacarpal angle. So 10 degrees severe, 10 to 20 moderate, more than and more than 30 would give you like a normal function. That's what I. So how do you in terms of severity, how do you classify the first wave contracture, Abdul Ghani? And how does influence your decision on the flap you use?
The most significant is the distance between the heads of the metacarpals, because sometimes you cannot measure the angle indeed, and even if you take an X-ray, it's a lot of exposure until you can see exactly the first and second metacarpals on the same plane. So the distance between the heads of the first and the second metacarpal, this distance will tell me how much is the narrowing. Sometimes the distance is the same distance between the knuckles. So it is a very narrow web. In the milder case, then you can measure an angle. So if the angle is about 40, sometimes it's 40-degree angle, but the web is advanced distally. So you have to recede it. And in these cases, sometimes I do 4 flaps at plasty and will do its job and will produce a very rounded web space, and I don't need to do many complex flaps. So once we can measure the angle between the first and second, this is not a severe contracture or narrowing of the web. If I cannot do any degree of abduction, and then it is a severe. I don't have a measure for a middle class. Indeed.
Okay. But so distance, of course, is a way to measure severity, but not in children, because the size of hand varies with children. And the intermetacarpal angle, I think it's the clinical measurement is okay. It's because with an X-ray you have to really separate the digits, and you really don't separate the digits because. But I think clinical is is better than radiologically.
Yeah.
Okay. So sometimes you use for flapseplasty, otherwise you go to your flap.
Yes.
Okay.
Okay. So then we're going to end this session for today. So please feel free to subscribe for those who did not subscribe yet. Otherwise, we will meet again on March 9th. I think Dr. Abdelghani will moderate the session. So there will be again 3 very interesting talks. So thanks for being on with us today, and I wish you a nice remaining Sunday, everybody. Have a good day.
Thank you.
Auf Wiedersehen. Auf Wiedersehen.
Auf Wiedersehen. Yes. Adios. Bye-bye.
Bye-bye.